Are you suffering with sciatic symptoms, which could be anything from pain in the buttocks, the hamstrings, further down the leg, and even into the feet? If you are, this is going to be the perfect tutorial for you. I'm speaking to Dr. Stuart McGill, who is one of the world-renowned back specialists, 30 years professor of spine biomechanics, and now works traveling the world helping people with their bad backs, training clinicians to help people with their bad backs. We're going to be going through and talking about content from his back mechanic book. So if you are someone with lower back pain, this is the perfect book for you. I'm going to put all the links in the description so you can go and find them. If you're a clinician, Low Back Disorder is the book for you. Much more technical information, much more in the way of how to assess people. But what we are going to do now is get straight into the tutorial, where we're going to be talking everything sciatica, all the way from talking about the structures that can cause it, postures and positions that can trigger it, and talking about stretches, exercises, and other therapies that could potentially help sciatica, or also could be potentially detrimental to sciatica. So that's enough from me from the introduction. Let's go straight over and start talking to Dr. McGill. So for the people that are maybe new to your information, or the people that maybe haven't heard of you and the information that you're sharing, can you give a quick background to who you are, why you're talking about these topics, and maybe just a little quick brief history of the career that you've had within this topic, I guess?
Well, good morning to you, Chris, or good afternoon in the UK, and good morning to the audience. I was a professor of spine biomechanics for over 30 years. I retired from the university 4 years ago, and now I just see patients who, special patients, not really local back pain people, but very special cases from around the world here at BackFit Pro, which is now located in my home. But over those 30 plus years, I ran two different laboratories, one where we measured the loads and the stresses on the internal tissues of the person's spine and associated tissues. Then the other lab was where we would take cadaveric spines and expose them to the various loads and motions, etc., to see what sort of damage or change and cascade of damage occurred. We had a radiology suite where we would match the images of X-rays, ultrasound, CT, etc., with the various loading scenarios. So that improved our understanding of the pathways to pain and change over a person's lifetime. Then about 20 some odd years ago, I started an experimental research clinic where patients would come in, all back pain patients, but they were special in that they were the failures. They were the ones who'd already been to a dozen or so different clinicians of various flavors, and they didn't get better. So we kept score, we followed up, we subcategorized their pain mechanisms. We spent 3 hours initially with each person trying to understand the various impediments as to why they never got better and what the mechanisms were, and tried to address them. We also did clinical trials on groups to see what we were discovering was actually making a difference. We tried to improve the assessment protocols to make back pain very specific for a person. So we created and trialed a number of assessment techniques. And we did epidemiological studies as well. Back injuries cluster around sport and around occupational groups for a reason. The sports and the occupations select a certain body type and physiology, basically through natural selection. And the exposure of that job or of that sport leads to the clustering of specific back injury. So we investigated the mechanisms of the whys and the wherefores there. So there's a quick 35 years plus.
A good history. Good. Now, for the people that have watched my channel for a period of time, or possibly some new people, they would have known that I've interviewed you before. But generally, around the broad low back pain topic, and what I thought would be good for today was to sort of go down a little bit more of a rabbit hole and start to look a little bit more specifically at sciatica. And for many people may know what it is. They may just experience the pain and not quite know what it is. But are you able to describe what sciatica is?
Yes, I'm going to use several models here, Chris, if you don't mind. And all of these models were produced by a wonderful company called dynamicdiscdesigns.com. I don't have any business relationship with them. It's just that they took a lot of the mechanisms that we investigated and put them into models that people can understand. So there is a pelvis, the pelvic ring, and the spinal cord runs down behind the main vertebral column, and at each level, at every joint, there's a pair of nerve roots that come out laterally and serve different parts of the body. In the lumbar spine, the bottom two joints, in other words, this nerve root coming off L5 and this nerve root coming off L4, form the sciatic nerve. That sciatic nerve travels behind the hip joint, down the hamstrings, and then dependent in the calf, it can be posterior in the calf, behind the knee, laterally down the calf. If the symptoms then go to the big toe, we know it's the fifth lumbar root. This one right here. If it goes to the little toes, for example, it's this one, L4. But nonetheless, sciatica is irritation of those two nerve roots, usually from a mechanism in the lumbar spine, but the symptoms can show up anywhere along that nerve's pathway all the way down to the end of the toes.
Excellent. Now, when it comes to the different structures, we've talked about or you've mentioned the pelvis, you've got the spine, you've got the nerves. Now, what is, I guess, or what different structures could be causing the pain as it shoots down the leg? And are there different ways of identifying what those different structures could be based on the pain that they're experiencing down the leg?
Well, absolutely. Yes, we can determine with a lot of precision what the mechanism of a specific sciatic symptom is. So let me start out by saying sciatica is a broad category with many, many subcategories. So let me start with generalizations. If the person is younger, let's say they're younger than 55 or 60 years of age and they have sciatica, typically it's from irritation in the lumbar region from a disc bulge. So the basic architecture of the disc is there's a nuclear gel inside these rings of collagen that form the disc. So you can think of a donut, if you will, as an analogous architecture. But nonetheless, there's a gel in the core, and sometimes that nucleus seeps through these collagen fibers as they start to delaminate with too many cycles of motion and too much load and that kind of thing. But I'm just going to squeeze the spine and bend it forward, and I will, there already is an existing delamination there. At the end of my finger, can you see the collagen opening up as it delaminates, and the hydraulic effort is posterior, pushing the nucleus through the annulus? Well, now let's allow the nerve to lay where it should, out of the foramen or the lateral hole. Notice that the spine is very mobile and it traverses up and down the spinal cord. So when a person flexes their neck, for example, it pulls the cord towards the head. If they extend their knee and sweep their leg forward, it pulls the cord down. So these are all orthopedic tests that shows, watch the nerve now to see how the nerve by the disc bulge changes, and you can tell whether the disc bulge is under the nerve root or over, called an overhook. So with certain orthopedic tests, moving and migrating the nerve around, you can be very precise in knowing the mechanism of the hook, what posture causes the hook on the nerve, etc. So that is common in younger people, and we follow the pain, the dermatome. It might even cause muscle weakness to certain muscles, but once again, that will give us the location back to the spine on where to look for that structure, as you call it, that's giving the distal symptoms. But there's many other causes of sciatica. For example, there are some people who don't have a disc bulge at all, and yet they have sciatica. Typically, the discs will be a bit more plump if you were to look at them on MRI. There's no disc bulge, but the disc has become a little bit lax. It's lost its stiffness. So consider a car tire where you let a little bit of air out of the car tire. The car tire bulges, but when you drive the car, it's a bit more sloppy. It's lost control. When a joint is damaged, it loses stiffness. If you damage a ligament, the joint becomes a little bit lax, if you can think of a knee example. So let me show you a spinal example now, where this disc is normal, it's undamaged. This disc has been damaged, and this one is normal. This one has lost stiffness. Now, you can't tell from a medical image like an MRI that it has lost stiffness. But watch, I'm now going to apply a twisting torque from above, and can you see how the majority of the movement is occurring at the disc that has lost its stiffness? Now, that causes sciatica in a number of people, but the pattern has now changed. If it's a disc bulge, the sciatic pain is the same. It's always to the right toe. It's always when you first get out of bed or whatever. The pattern is consistent. But when the pattern changes, sometimes my right sole of my foot might be numb, and then the patient will come in and say, but you know, this morning it was in my left calf. That is usually a sign of an unstable micro movement triggering the sciatic nerve. So that's an entirely different treatment regimen for that particular type of sciatica. Then typically, as people get a bit older, the spine becomes a bit arthritic. So this is a wonderful model, again, made by Dynamic Disc Designs. Here we are, where on one side we have a normal looking anatomy, but they've cut the spine, and on the other half, they've glued on an older person's spine, where you can see all this gnarly bone growth around the edge. This is arthritis. The facet joint has gone very arthritic, but the hole that the nerve root comes out when you're young is large. It's patent. The nerve flows as you move without irritation. But as you get older, and if you have a little bit of arthritis, you see all the bone growth around the hole now, and the nerve root becomes, it might be mechanically pinched, or it might be just getting frictioned. But what we would do in the orthopedic test is floss the nerve back and forth through the hole or through the foramen, and we would note the friction or if it's pinched. So there are many, many causes of sciatica. A couple of more come to mind. Another syndrome that is quite common among older people is there is a venous vascular system around the nerves and around the disc. Some people get what's called a vascular claudication. You can think of it somewhat like varicose veins around the nerves. And walking upstairs, for example, will add to the congestion, and they will get more radiating pain down their legs. Or we would walk into a swimming pool. Now, this will sound funny, but as you walk into a pool and it gets deeper and deeper and deeper, when you're just over a meter below the surface, the hydrostatic pressure of the water equals blood pressure, just about. And it milks all the blood back for free and changes the perception of the vascular claudication, or clogging up, if you will. So these are all very nice little diagnostic tools that we might use for that. And the final one, which is interesting, you may have heard of Piriformis Syndrome.
Mm-hmm.
So the sciatic nerve comes behind the hip joint, but the piriformis muscle also crosses the hip joint, and normal is to have the sciatic nerve go underneath the piriformis. When we measure it in people, quite often, more often than not, a person will come in and say, well, I've been diagnosed by my physio with piriformis syndrome because the pain is right there underneath the piriformis. But when we test it and assess it, it isn't the piriformis. It's usually something going on in the lumbar spine, but the symptom is perceived deep in the cheek of the buttock. But occasionally it truly is piriformis syndrome. They've been kicked there, perhaps in a soccer match. I remember one of your great soccer players from the Premier League coming over, and he had actually traumatized and had scar tissue around piriformis that was grabbing his sciatic root. We've seen anatomical variants where the sciatic nerve actually pierces the muscle, and you know, they can't cycle or perform an activity like that without flaring it up. So there is a little bit of a spectrum. There are some other more rare causes of sciatica that I won't get into, but it's age dependent, it's exposure dependent. But you know, Chris, most of the time it's treatable.
Sure. So what I thought we'd do now is we've talked a little bit about the different structures that can create the pain. You've mentioned some of the symptoms that can come out. So when it comes to the pain traveling down the leg to different parts of the leg or the foot, so you've mentioned about the pain on the underside of the outside of the foot, and I've heard like foot drop and things like that, pain in the toe. So thinking about the symptoms and sort of reverse engineering it, what's that telling us about sciatica?
Well, you're isolating mechanisms. So you mentioned a myotome, someone has foot drop. So now there are sensory nerves and there are motor nerves that traverse through that hole that I was showing, the lateral foramen in the lumbar spine. Sometimes motor nerves are affected and the person loses the ability to hold foot up. And that is from the sciatic root. So we can trace back to the level based on that motor deficit. Say that motor deficit was in the anterior thigh, then that goes up to not the sciatic level, but that is now a femoral root. So instead of sciatica, it's femoral rootica. I don't even know what the word is, but it's a femoral root problem. So pretty much anywhere in the body, you know, there are neck symptoms where someone has pain in the the fourth and the third finger. Well, that is a certain nerve root in the neck, if that's what the mechanism happens to be. But there are all kinds of neurodynamic tests that move the nerves certain ways. One might be the person lays on their back and raise up the left leg, stretching the left-sided sciatic root. However, the person says, oh, the pain just came behind my right knee. In other words, the pain was experienced in the opposite leg. That's called the sign of Fascial, which almost always indicates a central disc bulge. So the disc bulge is right in the middle of the cord, and you see there's a mechanical crosstalk. So with neurodynamics, if you stress the nerve on one side, it creates a stress to the other side. And if it is in such a manner, it might pull the other side nerve root into the offense, whether it's a bit of arthritis or a disc bulge or whatever it is. So a thorough assessment that really covers the mechanics, investigates neurodynamics, et cetera, a skilled clinician will get to the answer. And it's interesting with MRIs, for example, some people hold that up as the gold standard. Well, I have a disc bulge at L4, therefore that must be the cause of my sciatica. And yet when we test it, it's not L4 at all. It might be somewhere else. So even though there's a disc bulge, it might be joint laxity at L5. Do you see what I mean? So a surgeon might operate on the wrong level if they're just operating on the MRI picture. So my advice to anybody considering surgery, for example, because surgery is all about altering structure, I hope you get the structure right, but a very thorough orthopedic and neurodynamic exam will lock the clinician on target.
Great. Now we'll sort of move into, I don't know, movement and sort of go down the line of stretching, exercise, and look at other treatments. So are there different postures of the spine that are more advantageous or detrimental to sciatica? And again, what does it tell us about the sciatica? So for example, sort of if the spine's extended and it triggers the pain, if the spine's in flexion and it triggers the pain, and also I guess this might be the place to address some extra context around the McKenzie floppy push-up or something like that.
Yes. Okay. So the answer is it depends. There are some clinicians who, if a patient comes in with sciatica, they give them McKenzie floppy push-ups. That might make them worse, or it might make them better. Without an assessment, they're just trialing an intervention based on luck. Let's give it a try. Instead of, I would always advocate, the exam always leads the way. It changes the outcome for the patient from luck to science. I would much rather follow science. So if a person, I'll just give a pattern now, say a person is a strength trained person, they lift weights at the gym and that kind of thing, almost always, if they have a posterior disc bulge, the disc bulge is increased with bending forward. And I showed you that model, that the hydraulic effort is posterior. But now I'm going to give you a different characterization of the patient. Instead of being a strength training athlete, they are a mobility person. They really enjoy going to yoga class. They don't lift heavy weights. They don't stress their body. Quite often, those people, when they bend forward, the disc bulge reduces. It doesn't increase. They have very plump discs, but the collagen at the front of the disc buckles down rather than creating tensile stresses posteriorly and opening up the open fissure for the disc bulge. So do you see right there, once again, an assessment would show what is one person's cure is the next person's poison. So you might do floppy push-ups. Now, another problem that we see with floppy push-ups is a clinician might, it's a favorite of McKenzie trained physical therapists, for example. When you do a floppy push-up, you move the spine into extension over and over and over again. The theory being that you can pump or vacuum in the disc bulge back into the center of the disc. We were the first, I believe, to measure and prove that that is true. But it only works if a person has 70% of the disc height remaining or more. If they flatten their disc, doing a McKenzie push-up will probably just traumatize the disc more than it helps therapeutically. But the other thing that it does is there are facet joints in the back of the spine, and floppy push-ups in some people will irritate the facet joints, and in 2 years, they now have pain-causing facet joints. So when they move into extension, mimicking the floppy push-up, what was once a therapy is now their new pain. So they're traveling down a cascade now of perhaps solving one pain mechanism, but creating another. What we found was that instead of doing a floppy push-up, simply have the person lay on their tummy, perhaps with one fist under the chin. Don't move, just lay there. And we found that if they have 70% of the disc height remaining or more, it's just as effective at vacuuming in the existing disc bulge without traumatizing the facet joints and initiating that potential cascade. So there's an answer where I might say it depends. It might help. If floppy push-ups help, just do it for a few days and then stop, or go to the isometric tummy lay as I've described. Recall back to the other mechanisms that I mentioned can cause sciatica. So a venous congestion. Typically, the person is now approaching 70 years of age, walking upstairs, walking for 10 minutes, creates a sciatica symptom. For those people, we might advocate doing a pelvic tilt. So they will stand and just slight flexion and hold that posture. And then all of a sudden they say, oh, you know what? I don't get the symptom when I walk up the stairs. Or we have various, if I just go over to the patient table and demonstrate this, say a person gets sciatic symptoms after 5 minutes of walking. We might say, let's try a park bench decompression. In other words, go for a walk in one of those lovely English parks, and there is a park bench. I know there's a park bench in a park in Liverpool with my grandfather's name on it because their family put a dedicated park bench there. In any case, externally rotate the hands, put the heels of the hands on the back of the park bench, and I don't know if you can see what I'm doing, but I'm carrying the weight down my arms, and now I'm just bending my knees and allowing my hips to fall towards the back of the park bench, and just compress down, traction my spine in that position. It's uncanny that an older person almost half the time will say my sciatica left and I can now go and walk for another 10 minutes pain-free. Good, do that 3 times. They'll say you're magical. For the first time, cumulatively, I just walked 30 minutes. I haven't done that in 5 years. So these are some of the issues and thoughts around postures and movements and learning about the cause of the sciatica. The problem for the listener is, how do they get an assessment that shows them with precision the mechanism of their sciatica? We do have, I'm sorry for the promotion here, but the McGill method clinicians, if you go to our website, backfitpro.com, you will see a few clinicians around the world that are very familiar with how to perform a thorough and precise assessment that will reveal the mechanism of the symptom. Then that guides the person as to how to move, what exercises and stretches they should do, etc. There are some people who say, well, we don't have such a clinician in our neighborhood. That's why I wrote the book Back Mechanic. It takes the person through a self-assessment of 9 self-tests. Believe it or not, that's a more thorough assessment than they're going to get from most of their doctors and clinicians. But now they can subcategorize their pain, and then the book shows them what to do and what not to do to wind down the symptoms. So I'm sorry to have to promote that, but the reason I wrote it was the lack of expertise on the spine that they'd received from all of the clinicians that they had seen before.
Yeah, no problem with promoting. I'm now going to introduce well, sort of reintroduce, I guess, the Back Mechanic book. And in that, so if we now move along a little bit, can we talk about spine hygiene and sort of different activities? You've mentioned sort of a decompression there, but are there activities, movements that are more, again, sort of advantageous or detrimental for sciatica? What does it tell us about our sciatica? So, for example, I know there's an image and a little description of sort of pushing a vacuum around, or getting up from the seated position and things like that, lifting things into the back of the car, and all those different types of movements. So is it about the movements? Is it about how you do the movements? How does movement and spine hygiene come into sciatica?
Well, I have to explain two background phenomena here. The first is human movement in general can be broken down into fundamental patterns. So there's a squat pattern, a lunge pattern, a lift pattern, a gait, walking, carrying kind of pattern, a pushing, a pulling pattern, etc. So the book, and I might mention, I see behind you is Low Back Disorders. I wrote that book for clinicians. So the full detailed assessment for clinicians is in there, though that's a heavy read for the lay public. But in that Low Back Disorders book, we break down the movements to their components, and then it allows a clinician and the patient themselves to morph those patterns. So let me give an example here. I'm just going to walk back a little bit, and let's take a fundamental squat pattern. Well, if you ask a person to do a squat, they might do this, or they might stoop over. One might trigger their pain, one might not. I don't know which way it's going to go until we actually test the person. But let me just go into a fundamental squat pattern here. I'm going to shape my hands into a V between my thumb and my fingers, and I'm going to place those on my thighs such that when I run my hands down my thighs, my kneecap or patella will sit right in the V. And now I'm going to grab my knees hard. I'm going to become a leaning tower and push my toes down, and I'm going to lean forward through my toes. So I'm not falling back on my heels now. I've balanced up my weight on my feet. Now, at this point, I can change the curve of my back. I can hump up like a camel, or I can extend my back, which is the opposite. One might trigger the person's sciatica. Again, I don't know which way it's going to go on that person, but one might trigger their sciatica. So they're starting to learn now. That triggers my sciatica. That takes it away. Okay, now I'm going to maintain my spine in that pain-free posture. And instead of lifting with my back, I'm going to push down. I'm taking my shoulders down into my back pocket. I'm using my pectoral and latissimus muscles, and instead of lifting with my back, I pull my hips through. It's an entirely different mechanic. And now, if I didn't move my spine into the sciatic pain trigger, I've just learned how to bend down, stand up, turn around, pick up a weight, put it down, tie my shoe, etc. I can now reach and pull a door. I can reach a long way. I'm learning through that one little pattern in spine hygiene to not trigger the sciatica. Now, the interesting thing about pain and various subcategories of back pain is you don't get used to it. It's quite the opposite. The more some people trigger back pain, the more sensitized it becomes, to the point where everything hurts. And if I said to you, if you stubbed your toe or you bit your lip every day, over and over again, if you lightly touched your lip or you lightly touched your toe, you'd be screaming. It's centrally sensitized. So are you going to do an exercise for your lip or an exercise for your toe? No, you're going to stop stubbing it. Take the offense away. Spine hygiene takes the offense away from repeatedly hammering and banging the pain mechanism that's in the mechanism of sciatica, it allows it to wind down and desensitize. So some people will say, oh, we do the McGill Big Three exercises and it didn't work. Yes, but you didn't read the book. That's not where you begin. You begin by recognizing the mechanism of pain and wind down the sensitivity through spine hygiene. Now, the book shows lunge patterns, pushing patterns, pulling patterns, etc., etc. Then you've now created a capacity, an ability for the body to receive those exercises so that they can now perform the adaptations, which is the therapy that the person needs. So it's a little bit of a method, I suppose. I don't know what the spine hygiene is for a patient. We'll figure it out when we see them, or when they read the book, they'll figure it out. Then they'll know how to move in patterns that do not trigger the pain. Then they build a pain-free foundation by tuning their body a certain way. More mobility might not be better. More stability may or may not be better. We don't know, but the assessment will always reveal the way. So I don't know if I meandered on that question or not. Maybe you want to bring me back to the central point.
No, it's very much covered, really, because it's talking about the advantageous movement, and you've explained that with within the sort of the boundaries of it can work for some and it can work for others, or it might not work for others, for the very simple reason we don't know what the pain triggers are. So that,
right,
in some respects, is the main part we've covered. It's not just what you perform in some respects, it's how you perform it as well.
right.
But
I mean, I'm sitting on a stool, Chris. So if I may, if I see someone with their knees together, just let me pull the camera down a little bit. If I see someone sitting with their knees together, and the first move that they have to make to get up out of the chair with their knees together is to bend their spine forward and then lurch up. Well, if they've already done the assessment and figured out, well, that's what causes my sciatica, that takes my sciatica away. You see, they've just guaranteed sciatica. Instead, we might say, let's spread your knees, get your feet underneath you. Now, the first move will be to sniff some air, lift your chest, pick a point on the far wall and gaze at it, lean forward through the hips and then pull the hips through. And they'll say, oh yeah, now my sciatica is gone now. So, you know, it's when I explain it and patients work with us, you know, some of them get quite annoyed. They'll say, this was so simple. Why hasn't my physio or my osteopath or my chiropractor shown me this?
and
And
even from sort of my level, I'm only a personal trainer, but it's maybe not held as in such as regard as a physical therapist or a physiotherapist, as we call them. But I will explain, in some respects, as you just explained, the simplicity of it and how effective it can be. And, you know, I don't want to say they don't believe me, but with the, I don't know, the qualifications that I hold, it maybe doesn't carry the weight that it really should. And it's a very strange thing to communicate, because it is, you know, it is simple. We're looking for pain triggers. We're trying to eliminate those pain triggers and, you know, move within that capacity and then build that capacity. But yeah, a lot of people do think it needs to be harder.
We have in our family of clinicians, we have the highest level of clinician called a master clinician. Some are MDs, doctors, do you know, some are trainers. And the reason is they have the eye that can see the movement, that is now trained through special education to see the offensive movements and then to prove that they are there through an assessment. So, you know, I know some car mechanics who can build an F1 race car who never went to school. So, and yet the next person is an automotive engineer and they can't even create a car to win.
Yeah.
So anyway, there's my thought on that. Look
Sure.
at who the masters are in any profession.
Yes.
And you will see there was a lot of paths to obtain that mastery.
Hmm. So if we can move on to stretching now, because I know there's maybe some thoughts on stretching and how that can affect sciatica. Maybe describe more effective stretches and, let's just say, least effective stretches.
Okay, well, you're getting to know what the answer is going to be, and it depends on the person. So I can think of cases where the sciatica really was involving a muscular-based tension issue, or they had a hip problem. So when they got out of the chair, they were binding up one of their hip joints. It didn't move properly. So guess what had to move? The next joint up, which was the spine, causing their sciatica. So again, the assessment shows what is the clinical target to reduce the mechanism. If it involves a joint with tight muscle, stretch that joint in a way that is consistent with the science. But now it gets so interesting. Some people will say, oh, if you've got sciatica, pull your knees to your chest, curl up like a ball, stretch it out. That might work for some people, but here's the interesting thing. Two things. First, you're firing a stretch reflex. The stretch reflex in the back provides, on average, about 15 minutes of analgesia. So the person thinks, oh, I just got rid of my sciatica, but they didn't realize it's back again in 20 minutes. And it never goes away. So they get into this repeated stretching mobilization cycle, but it doesn't address the cause. For that particular category of patient, I'll say stop stretching. If you feel the need to go and stretch your sciatic root, lay on your tummy and breathe in a way that we instruct to just relax. That feeling to want to stretch will go away in 3 or 4 days. And then they come back and say, you know what? For the first time, my sciatic symptoms are starting to abate. If you have an angry sciatic nerve, very rarely does stretching the nerve desensitize it. It does the opposite. It sensitizes it. Now, muscle can be different. You can stretch muscle and desensitize it, but very rarely a nerve. Now we get into a discussion not of stretching, but of flossing. So I showed how much these nerve roots floss. So we measured just on one side in cadavers that you can get over a centimeter of movement with certain neck movements, arm movements, hip and knee movements. And my colleague in Finland, Professor Olavi Eiraksinen, showed that when you do some of the nerve flossing techniques with both legs, it almost doubles that nerve migration. Well, the nice thing about getting a nerve to floss is if you've got a fresh disc bulge, as I showed in this model, quite often the body's reaction is to create inflammation around the nerve root. So if there is an inflammatory nerve root, well, we'll just call it soup around that area, flossing the nerve back and forth helps clear out the soup. And some work by David Butler's group in Australia, for example, have documented the ability of the nerve movement to clear out faster some of the inflammatory soup. So that's not a stretch. That is a mobilization of the nerve root. We had a patient, and it's in my mind now because this was just a week ago, where they had a little bit of a compound scoliosis to their back. So if you looked at their x-ray straight on, seeing the frontal plane of their body, they had a little bit of a curve out of their lumbar spine tilting off to the left, and through their lower rib cage, it made up for it and tilted the other way. But on the x-ray, you could see bone spurs pulling off the vertebra just on the side of the concavity. Bone spurs is the body's response to tension. So if there's unequal tension, that where the structure connects to the vertebra, it grows a little bone spur. There was something pulling the spine into that scoliosis. What we then did was a fascial stretch. So we pushed the arm up on one side, we pushed the heel to the ceiling, we went into full internal rotation, and then we extended the hip on that same side. And then we just put them on a Bosu ball on their back, and they enjoyed that particular stretch. They stood up and they said, "Doc, you're amazing. My sciatica is just gone." It is just gone like that. So again, it was the mastery of understanding the mechanism of their sciatica. It was a complicated case. No one had helped them. It helped me to see the asymmetry of the tensions in their body, and then to see the X-ray radiological evidence of where the body was trying to lay down bone that unlocked the way forward for them. Now, if you were to ask me, so what was the structure causing the sciatica? I can't tell you, but I can tell you by putting those clues together, we tried a full fascial stretch. It wasn't random. That's where the clues led us, and their sciatica went away. So I've given you cases for stretching will make some sciatica worse. Flossing, which is movement, anti-stretching, can be helpful, or it can be, it's tickling the dragon's tail. You can create a raging sciatic fire if you floss the wrong candidate. And we have several tests just to try to see if the nerve is flowing or does it have friction in it that will flare a person up. And now I've just given you a case of a very special type of stretch. So do you see how never ending this issue is? But I must sound like a broken record, but it comes back to the mastery of the assessment that will reveal the cause of the person's sciatica.
What you just said about sort of hammering it's needed, because even the people that I will speak to about it, they will say, what exercises should I be doing? What stretches should I be doing? And as you've mentioned before, the exercises and stretches aren't where you start. You move into that at the appropriate time, which leads me into the next question, which is where we move on from stretching into exercise. And where you've mentioned it before, it's not where you start. How does exercise fit into a rehabilitation program for sciatica?
I'm going to hammer it again. The assessment and the exam reveals the specificity of the mechanism. So once you've got that down, now you've got a roadmap. Does the person have joint laxity, as I showed you here? All right. If they say, my pain is worse, the final 2 hours I lay in bed, and the first hour I get up out of bed, and I will say, let's have a look at your mattress. Is your mattress allowing you, you're a side sleeper, to allow that joint that I showed as lax to go into that deviation that triggers that deep sciatic pain? Let's try tonight a half-folded pillow under your waist, and let's see how you are tomorrow morning. And if the patient says, I woke up without sciatica, you found the way. So what exercise was that? It was modifying the mattress to avoid the deviated micro movement at a single joint that address the mechanism of their sciatica. The next thing might be, let's try the big three, which is the bird dog, the side plank, and some form of a modified curl up or a plank for the anterior abdominals. What we found with those exercises, and the reason we converged on them, there are many reasons, but one of them is there is a neurological holdover effect to the stiffness. A person will stand up after doing the big three and they say, you know what, my sciatica is gone. And in fact, it's gone now for the next 2 hours. Good. The neurological stiffness has held the joint in place, avoiding the pain trigger. For those patients, we might say, do those exercises once mid-morning and again mid-afternoon. You've just guaranteed yourself 2 periods of the day to wind down the pain sensitivity. So do you see the exercises might be stabilizing in some areas of the body, they might be mobilizing in other areas of the body. The prescription, how many times a day, how many sets, how many reps, what's the rest period to allow the adaptations to occur? It's, if it was easy, everybody would be able to do it and fix it, but it isn't.
And
Anyway, that's how the book's back mechanic will guide most people out of pain. Not all, not all.
Yes, and I think that's a big part of it. Just explaining that last bit, I was just quickly writing a quick note to follow up. I think you covered it, which was many people are expecting the purpose of exercise is to reduce the pain. Certainly the ones I talk to, because that's what they ask me for, and it's sort of explaining to them that it's not directly there to reduce the pain. There are other mechanisms for that. It can help, as you've mentioned, by stabilizing the joint if that's what's creating the pain. So there is a purpose for exercise. It's just maybe not what people always think it is. Which
I think the way to frame that, Chris, is to say to people, the exercise is a tool. It's a tool to achieve a goal. What is the goal? The assessment reveals the goal. So, you know, they get it in a sports world. If I want to be stronger, I do these specific exercises. If I want to be faster, I do these specific drills, a little bit of stretching, a little bit of strategic power development, a little bit of neurological development. But for some reason, when it comes to pain, the exercises don't become tools anymore. Oh, give me the exercise to take the pain away. Well, if I had a sore thumb, oh, that's my thumb. If I had see, I only know my body parts between here and here. When you get out to these complicated parts, I forget the names of them. But if I had a sore thumb, you know, oh, give me an exercise for my sore thumb. Well, leave it alone for a few days. And then we'll build some resilience according to what is the mechanism that we need to build some resilience for. So yeah, isn't it interesting? If they could consider rehab performance training, I think that question would go away.
Yeah, it needs to be sort of framed in that way somehow. I think it's slowly sort of filtering its way into the public's consciousness, but you know, I suppose like anything, it takes time.
Well, there are always those experts, particularly these days on social media, where they have a quick fix, but boy, they're good marketers.
Oh yes, a very
and they're much more effective than people like me at getting a message out.
Oh yeah, and that, you know, that's unfortunately a part of the world, a very good marketing persona. So the final question is now moving on to other therapies, and I guess considering them as tools. So it could be massage, it could be osteopathy, it could be chiropractic, it could be yoga. How do other therapies fit in? Are some more useful than others? Can you explore that and how that will affect sciatica?
Every one of those approaches that you just mentioned, chiropractic, massage therapy, osteopathy, are non-specific. Let's take yoga, for example, which might be a collection of, and you know, I think about my work over the years with yoga and with high-level practitioners of yoga. So when I get someone from India who is a high-level practitioner of yoga, the reverence that they give to what they do, the discussions we have usually involve, well, I'm transcending my mind to reach this level. Do you know what I mean? It's a very cerebral, mindful practice. In the UK, in your country, and in Canada, they never enter into those discussions. It's a sport. It's a can you get your knee over there? And do you see what I mean? So the Indian origin seems to be bastardized into yoga being a sport or a therapy. There may very well be some specific yoga poses that will be very beneficial for that individual's sciatic mechanism. For the other 3 exercises that they're doing in their yoga program, it might be poison. So to do yoga is, it doesn't work for us. We might choose a specific tool from the world of yoga for that individual. And I would say that about Pilates, osteopathy, or anything else. We've got to make it specific so that the person isn't working on luck, trial and error. Oh, let me try some yoga. Let me go with a yoga teacher now. For example, I might use the example of Bernie Clark, who wrote a book called Your Spine, Your Yoga. He's got another book, Your Body, Your Yoga. And we've collaborated a fair bit. He takes the yoga students through a self-assessment and then tunes the yoga for them. So, oh, you've got shallow hip sockets, you move on this side of the room. You've got deeper hip sockets, you go on this side of the room, and we will de-stress your back and the sciatic nerve roots. And so just that simple subcategorization or dichotomization will greatly improve the class's response to the yoga, which is no longer the transcending, it is to make their bodies feel better. Anyway, I'm just going to leave my answer at that level.
Sure. Yeah, no, with regards to the Western yoga, it's very interesting. I've delved into the history of it a little bit, and a lot of it converges. It was in the early 20th century, late 19th century, a lot of the yogis came over to Europe and the West, and they used to try and sell it to the masses in the West. They used a lot of Swedish gymnastic manuals to create, I guess, their poses and their flows based on those Swedish gymnastics, because I guess the real, if that's the right way to say it, Indian version, they didn't think would sell. So it's quite interesting that, you know, there's the I guess the quality and the difference between the Indian and the let's just say the Western style of yoga. But anyway,
right. I mean, I think of the Indian trained yoga masters, yogis that I've worked with. I can't think of one of them who lifts weights. And yet in UK, there are many women who will take yoga classes and then lift weights and wonder why their hips and their backs are painful. Those tools will fight one another. It's a little bit more scientific, the tuning of their bodies to reach optimal performance.
Sure. Okay. This has been
Boy,
excellent.
isn't it being a trainer? I'm going to say this, Chris. It's a bit off topic, and you didn't ask for this, but I'm going to say this. Think of every health system in the body, and the determinant of health in every case is movement. You can talk about cardiac health, various neurological systems, digestive systems, psychological systems, and certainly musculoskeletal. Every single one will thrive or become compromised because of appropriately tuned and exposed movement, and the opposite. Now, you'll see the logic of where I'm going on this argument. Who owns movement in the whole spectrum of healthcare? Is it your family doc? No. If you go to them with a musculoskeletal disorder, they're not going to prescribe movement. They're probably going to prescribe an analgesic. Is it your surgeon who's going to say, no, here's some specific exercises and ways to move instead of my knife is going to alter your anatomy? Is the psychologist going, no, who owns movement? It's the trainer. So when you give me that explanation that you're a trainer, I'm going to turn that right around and empower you and say the trainer is the one in the whole spectrum who owns movement. Movement is potentially the most powerful determinant of the lifelong health of their clients. You screw it up, that's a hell of a responsibility. If you get it right, it's fabulous. So don't tell me you're a trainer. Tell me that you have the largest influence on the lifetime health of your clients.
Yeah, I'm mainly talking from the, I guess, this perspective of the perception of a trainer that comes from, because I can walk into a room and I kind of get an impression of the way people talk to me, because it's held in such a bodybuilding style. That's the sort of the mainstream way of training, and you know, there's a place for the bodybuilding style, but I'm trying to share a different message, I guess, and trying to get that across, to get through that perception that's held in their mind, to really get them to understand what I'm trying to do for people is.
No, I appreciate what you're trying to do, and I apologize for the lecture. I didn't mean it to come across as a lecture that way at all, but I do appreciate all that you're trying to do
yeah,
here.
to try and get someone else but me talking about it. So for you mentioning it, I'm you know, more than happy with that, because it's not just coming from me. I'm the one with the qualification, therefore I'm going to promote that. A chiropractor will promote their surface type of thing, but to have it someone who's maybe from a neutral standpoint saying that, you know, that there's value and there's use in movement for health, then it's only going to help my cause, which is, you know, what I'm trying to bring to people.
I agree.
Well, thank you so much for your time. We've been talking for somewhere close to an hour, so I think we've covered all the points in more than enough a depth. So what I will do is I will let you carry on with your day, because it's still only early in the morning in Canada. So many thanks for joining us, and I'm assuming at some point in the future we will come together again and talk on another topic.
Thank you for all you do in bringing awareness to this, Chris, and I enjoyed it very much today. Thank you.